Hello, Dr. Rotchford here again on the next session and episode, if you like, of Opiate Use Disorders. This discussion today is kind of boring in some ways. That is to say, we're just talking about naltrexone or antagonist therapy for opiate use disorders. Now, I don't want to go into all the research and all the pros and cons about naltrexone and its use in opiate use disorders. That would be really boring for most of you. But if you are interested, you want to know the details or some references, there is a paper published by the American Society of Addiction Medicine regarding guidelines in opiate use disorders. And it talks about all kinds of things that could be helpful in addressing and recognizing opiate use disorders, even in certain populations, whether in jail, pregnant, whatever. And it's available. A link is there on my website, drrotchford.com, under handouts. But it was published in 2015. It's really up to date. If you want all the research and standard guidelines for what might or might not be used for opiate use disorders, I recommend you taking a look. Now for today, what I hope to provide to you in terms of just some, if you like, one-on-one clinical opinions about naltrexone. I think there's a subgroup of patients for which it can be very helpful, period. Who are those patients? That's the challenge. There are no biomarkers to guide us in the severity of the disease. It's not like high blood pressure or blood sugar levels that help me as a physician determine whether a patient needs insulin or not. With opiate use disorders, the history is primary. And as a result, there's a lot of grayness in terms of determining the severity of the illness, period. It's easier for me as a physician to determine that a person has an opioid use disorder than to be certain as to its severity, that is mild, moderate, or severe. I'm challenged by that. I've seen patients who seem to have relatively minor problems, but definitely don't do well without agonist therapy. What I'm getting to is this. I don't think naltrexone is very good for patients with moderate to severe disorders or don't have other serious and important structure and support in their recovery. So who are those patients? Well, one study looking at doctors who developed opiate use disorders seemed to demonstrate that they did okay with naltrexone. The problem is, for me, is what is okay. In most of these studies, the outcome is lack of use of illicit or non-prescribed substances. For me, that's not enough. Does their life improve? Are they meeting their full potential? Are their brains working as well as they could? I think these are more important questions. As we've talked about before, in some cases, abstinence is the best indicator for a good outcome. But as I've emphasized over and over, with opiate use disorders, we cannot assume that to be the case. There's ample proof and evidence that with opiate use disorders, agonist therapy, medical assisted treatment, if you like, is indicated and helpful and promotes the best outcomes. We can't simply be limited to abstinence as our final outcome measure. As helpful as it may be in certain substance use disorders, I don't believe it's the case with opiate use disorders. Nonetheless, there are advantages of naltrexone. It's not controlled. There's not all the rigmarole with having to get access to it, problems with diversion, etc., overdoses, abuse, all that good stuff that comes when you're prescribing a controlled substance. So if naltrexone really worked and could provide for the optimal outcomes that we're hoping for all patients, I'm all for it. I'm just not sure who those patients are, and I suspect it's a distinct minority. Let me just end this discussion comparing it to my trying to decide which antibiotic to use on a patient. Let's say someone has a community-acquired pneumonia, and I'm trying to figure out the best antibiotic. Perhaps penicillin would work in 30% of the cases if it's bacterial, because penicillin still remains quite effective for pneumococcal pneumonia. Then I could maybe up the ante and go to erythromycin to take care of most of the common causes, and maybe it would take care of 60% of the cases. And then maybe, I don't know, ciprofloxacin or one of the newer antibiotics could be used even with a greater chance of success. The point is that even with established conditions, objective as they may be, I think pneumonia can be clearly documented on x-rays, and severity could be assessed. There are different approaches with different likely outcomes. With regard to opiate use disorders, I don't think there's any controversy. Methadone is the most effective medicine to use in the vast majority of cases. Next is buprenorphine, and last, naltrexone. So, just as in the case with pneumonias, if penicillin works, great. I mean, geez, it's safe, it's simple, it's cheap, it gets the job done. But wait a sec, it's only going to help in small minority of patients, so maybe it's not the safest. Again, it's problematic, particularly for us in opiate use disorders, to determine for sure what medication-assisted treatment is going to be most likely effective for a given patient. There are a lot of contextual variables, let alone trying to assess the severity of the disease. So I hope that helps. I mean, just like other areas of medicine, we do the best we can. In general, this physician, if someone has a moderate to severe opiate use disorder or anything that resembles that, or has other risk factors or complications, and cannot afford or be assured of adequate support and structure, or has other comorbid problems like pain or psychiatric issues, I'm not going to talk about naltrexone. I'm not. I think agonist therapy is the best treatment for those patients. So I hope that helps, and hope that's some further good news. All right, till next time. Thank you.